Thank you very much for organizing this great event. I thought this morning was fascinating, but I'm going to take it in two slightly different directions now. First of all, instead of talking about just medicine, I'm going to be talking about clinical judgment in the context of psychotherapy, which involves psychotherapists and clinical psychologists as well as psychiatrists. And I'm going to try to, get a sort of middle ground over the question of what the judgment should involve. I guess the two extremes, you might think of them as the rock and the hard place this morning, would be Bayesianism as the rock and hermeneutics as the hard place, or perhaps more accurately, the soft place. And that's what I'm going to try to show an alternative to both of those. This work is collaborative with Laurette, who's a psychotherapist in Guelph, Ontario, who's working today. Okay, so let me start by telling you a story that will illustrate some of the problems of clinical judgment. There's this first story is about a convent where the Mother Superior gathers all the nuns together and says, "Sisters, there's something I have to tell you. The convent has a case of gonorrhea." And then dead silence, but at the very back of the room, an elderly nun is heard to mutter, "Thank God, I'm so tired of Chardonnay." Okay, miscommunication. Here are other cases in real situations. Psychotherapist I know told me she had a young man who was saying that something that sounded like I'm washing corn. She says, "What? You're washing corn?" And he said, "No, I'm watching porn." Okay. Another case of miscommunication. I was talking to a physicist who told me that she had a patient who was diabetic and just wasn't getting any good numbers, despite the fact that he said that he was complying with all the instructions. But then he happened to mention later on that how excited he was about his new candy machine that could dispense 500 pieces. She also told me that it's standard practice that, and this is psychotherapists do the same thing, that if you ask someone how much they drink and they tell you, well, you double it because you don't expect that they're telling you the truth. So, and dealing in a situation where it's not simply a matter of going directly from symptoms to a diagnosis, you have to have all sorts of complicated interpretations of what's going on. And I'm going to give an account of how I think that works. So here is the outline. I'm going to lay out what the problem of psychotherapeutic assessment amounts to, and then give several different answers to how it might go on, how the clinical judgment actually gets made. One would be a simple kind of pattern recognition, where you're able to take what people tell you and match it to a pattern. I don't think that's nearly adequate. Another is more complicated kinds of causal reasoning, which I think is what people are aiming for, quite legitimately. But I'll say why I don't think that the Bayesian models can handle that very well. Alternatively, I'm going to mention a different kind of model, which I think does capture both the interpretive and the reasoning aspects of this sort of thing, my model of explanatory coherence, which I've applied over many years to different cases of scientific reasoning, but I think it works very nicely for psychotherapeutic assessment as well. If I have time, I'm not sure I will, I'll talk about the pragmatics, because one thing that's important to recognize in these clinical situations, it's not just a matter of coming up with a scientific interpretation of the problems that the patients or clients are presenting with. It's a question of figuring out how to treat them. And so there's really interesting interconnections between the inference about what the problem is and the questions of how to treat them. And finally, if I have time, I'll talk about some of the errors that arise very naturally in psychotherapeutic assessment. Okay, so what's the assessment situation? This can involve psychiatrists, clinical psychologists, psychotherapists. Increasingly, it involves family physicians. In Canada, a lot of often the first line of treatment for these sort of situations is going to be the family doctor, so they need to perform assessments as well. What kind of problems do people present with? They have depression or anxiety, stress, including in some cases post-traumatic stress disorder, various social problems, relationship problems, marital problems, in some cases psychosis, such as manic depressive illness or schizophrenia. These are all ones where the clinician has to figure out what actually is the problem. So, as I said, they not only have to identify the problem, they need to plan some sort of treatment. So the question I'm interested in, and here I'm doing this both from the perspective of philosophy of science, but there's another hat I wear as a cognitive scientist, what's going on in their minds to figure out in the minds of the therapist or the psychiatrist, what's going on in their minds to figure out what the person's problem are. And of course, how does this lead into questions of treatment? So here's some of the interesting questions. Well, how do the psychotherapists identify problems? And with many speakers this morning, I'm interested in both the descriptive question of how they do it and the normative question of how they can do it better, more accurately, and more suitable for the goals of the clients, the patients. One question I think is really interesting: is assessment the same as medical diagnosis? Is there something different about a psychotherapeutic situation that makes it different from what the physician faces? What are the cognitive processes behind it? And then how does the assessment link with treatment? And then what are the errors? Okay, the first answer that would jump right out if you figure out what might be going on would be just a basic kind of pattern recognition. Every psychotherapist, psychiatrist is familiar with the Diagnostic and Statistical Manual of the American Psychiatric Association, DSM. It's now in its 5th version. And this lists hundreds of different disorders where you can get a set of symptoms. It looks like criteria. And so it would seem that what diagnosis amounts to then is simply a matter of going through that list, figuring out what the patient's problems are, and then just simply doing a simple pattern match. It should be a very simple kind of reasoning. So here's an example for depression, so that if the clinician thinks that the problem is depression, well, DSM tells them that they need to figure out whether somebody has 5 of the following 9. It's a little more complicated than that because they have to have at least one of the first 2, depressed mood and markedly diminished interest, but then a total of 5 adding up, so it would be at least 4 of the others: weight loss, insomnia, trouble sleeping, psychomotor agitation, fatigue, worthlessness, guilt, diminished ability to think. And so this should make it sound as if clinical assessment would be fairly easy. It's just a matter of going through a checklist. But I think there's a number of reasons why that isn't right, that I think maybe there are some psychotherapists who simply do just sort of click off some boxes. But my guess is that the good ones are doing something more complicated. One of the problems with just thinking about pattern matching is that the patterns would encourage mere counting rather than assessment of importance, especially for the purpose of figuring out what the treatment's going to be. You've got to figure out which of these symptoms really matter you're going to have to deal with. So it's not just counting. Another problem is that the disorders overlap a lot. On these hundreds of different disorders that are listed in DSM, there's lots of overlap in some of the symptoms. And of course, the possibility of comorbidity is really high, the possibility that people have more than one. A really common pattern, for example, is for people to have both depression and anxiety, and that's going to require ways of treating them. Another problem with the list, and everyone agrees with this about DSM, that it's really still just a stopgap. The hope for DSM-5 was going to be that it would be more principled than the earlier versions. It wouldn't just be a bunch of symptoms. It could be based on a causal understanding of how diseases work. I mean, this is the way diagnosis has worked in modern medicine since the middle of the 19th century. Before then, there were just sets of symptoms. But once you have an idea of diseases being caused by particular mechanisms, such as bacteria or viral infections, or later on nutritional diseases, autoimmune diseases, you have some idea of the causal underpinnings of the disease. And people have been very frustrated in psychiatry not to have that kind of causal underpinning. But some people, the National Institute for Mental Health, they don't allow any research that's based on the DSM categories because they don't seem very scientific. They just say, oh, you have to have things that are more based on biology. Another example is, another problem with just matching is that it doesn't really help you as much as you need with the real question, which is the question of what kind of therapy to do. Now, of course, you could have a sort of textbook approach and say, oh, they match 5 out of 9, so they've got depression, so we'll apply cognitive behavioral therapy. Well, cognitive behavioral therapy is helpful for lots of people, and it's fairly straightforward, and insurance companies like it a lot because it's short, and you can even do it online. But still, there are lots of problems for which it's not appropriate. And so you need to have ways of figuring out more deeply what somebody's problems are if you want to treat them more effectively in a psychotherapeutic situation. So what I think that psychotherapists need to come up with, or psychiatrists or clinical psychologists, is some idea of what the causal patterns are. What's the causality? What are, for example, the stressors? What kind of stresses are some people under with economic problems or occupational problems or family problems or educational problems? It also helps to find out in the initial assessment interview what the triggers are, what is precipitating the current problems that the person has, and as well as getting at the symptoms. So it's not just trying to find out what the symptoms are, it's trying to figure out where they came from. So you get a causal model where the stressors and the triggers together are producing the symptoms. And so the ideal would be to try to get an idea of what this causal structure is so you can figure out where to intervene in it. Where can you block the different kinds of factors that are creating the depression or the anxiety or the other problems that clients have. Well, now that I'm talking about causal models, you might think, well, why not be Bayesian about it? I mean, Bayesian views are very popular in philosophy these days. They're very popular in psychology. They're technologically really powerful. All the current driverless cars that are becoming more and more prevalent use Bayesian models. So it really is a powerful way of operating. But I really don't think it's appropriate in the psychotherapeutic case, and I have doubts in the medical case. Although in the medical case, the databases are getting more larger and larger, and so you get more of the statistical information that's relevant. But in psychotherapy, it's not. So, but why not be Bayesian here? And some of these, I think, will carry over for reasons not to be Bayesian in the more broader medical cases. First of all, the probabilities are largely unknown. I mean, people just don't know what the conditional probabilities are tying depression or anxiety to different kinds of symptoms. Now, perhaps there are areas of medicine now where much more electronic data collection allows people to get that, but it certainly doesn't operate in psychotherapy. So we just don't know the probabilities. I highly recommend to anybody who is keen on Bayesian models is to build them. So there are lots of computer tools now. I used one called JavaBase when I did some work on legal reasoning a few years ago. And so you can get these nice little packages, and then you can not just talk about the model, you can build a model. And when you do that, I did this for legal reasoning cases, you find, oh, it's so hard to figure out what the probabilities are, because it's not just simple probabilities of this given that. You need to have dozens of probabilities that you simply have to concoct and pull out of the air, and those simply aren't known. At a more philosophical level, there are real difficulties about what probability is. The syntax of probability is unproblematic because we know Kolmogorov's axiom, so that's not a problem. But the semantics of probability is really different. People were mentioning today two different interpretations of probability. One, the frequency account, which I think is the one that would be best if you're going to be doing things in an evidence-based way, but that doesn't always apply here. But degrees of belief is what Bayesians often go to. But why suppose that people's degrees of belief are anything at all like probabilities? In fact, I think there's lots of psychological evidence to the contrary. I actually don't think that either of those interpretations of probability is the best in this case. There's another new interpretation based on mechanisms that I think is more plausible, but just give you some idea that you can't assume that, oh, probability, that's got to be the way to go. You got to have some deep understanding of what you mean by probability in order to do it. I already mentioned the question of the psychological difficulty. People were saying this morning, every doctors have always been Bayesian. I don't think that's true at all. You have to realize probability theory is a recent invention. It only goes back to the 17th century. Bayesian inference is an even more recent invention. I don't think it's naturally part of our cognitive architectures of the way our minds work. Sometimes it's a really valuable tool to put to work, but I don't think that's actually a part. One of the issues here that I'll get to at the end of the talk if I have time is that an account of reasoning should not only be able to explain what people are doing when they do it right, but also the errors. There's a large literature in medicine on the errors that doctors systematically make. And so if it's going to be account of the mind, you should be able to explain why doctors make those errors as well. And I actually think the view I'm going to give can explain errors as well as how things go well. There's also loads of things that are missed out in Bayesian methods. Other relevant psychological processes that I think any clinician is going to engage in. One is analogy. Is it legitimate to think back to previous cases? My guess is that physicians do this all the time, and I'm sure psychotherapists do. They think back to, I had another client with something similar but a little bit different. Empathy. How do you get empathy into a Bayesian account? But there's evidence that this is actually an important part of the psychotherapeutic process. People get better when they have a psychotherapist who empathizes with them. There's another couple of findings that are interesting. Also relevant are trust. Also relevant, so this one I just learned about, is alliance. That is, people do better with psychotherapists who they consider to be working with them on a joint project to get them better. Now, you might think maybe that stuff doesn't matter in the medical situation, but I think it does. One of the biggest problems in medical treatment is that people don't do what the doctor says them. Non-compliance is an enormous problem. You find that in 50% of people don't take their medications. Well, if the people actually trust their doctors and are in an alliance and feel like there's some sort of empathy, then you've got better chances of that. And another thing that I think is missing in the Bayesian account, it assumes a complete divorce between the two steps. One is the diagnosis and the other is the treatment. But a number of physicians, as well as the therapists I've talked to, like to see these as intermingled, right? The moment the person walks into the office, they're thinking, how can I help this person? Because that, after all, is the point of it. Finally, there's lots of technical difficulties with Bayesian networks. You might think, oh, it's just a matter of calculating probabilities. But computationally, this is a really difficult problem. To do Bayesian updating with more than just a few variables turns out to be intractable, no matter how big your computer is. There's also weird loops that will operate. So there's lots of reasons to be suspicious about Bayesianism as an account of how people think, and I think they're sufficiently serious that they also undermine the idea that this is how clinicians ought to think. So the Bayesian route isn't, I think, the good one. But I think there is an alternative to the hermeneutic route as well. This is one I've developed over many years. And it fits very well with some of the things I've read in the literature on psychotherapeutic assessment. Morrison's the author of a book called The First Interview, where he says, the best diagnosis most satisfactorily explains the data, signs, and symptoms of illness. So in philosophical terms, this is an inference to the best explanation. You've got lots of things to be explained. You want to come up with the best account. How do you do that? Well, you often requires layers of causes. So if you consider what a detective does, a detective not only is going to have a bunch of clues, those would be like the symptoms, but the detective's also looking for motive. Why did the person do it? And so you have to have whole layers of these. Well, I got the idea quite a long time ago when I first started working with neural networks that it would fit very well with the idea of explanatory coherence. The idea of explanatory coherence comes out of philosophy in the 1960s. Philosophers like Wilfrid Sellars and Gilbert Harman claiming that this is really the basis for developing knowledge, but it was a sort of vague idea. But once I translated into the sort of computation that neural networks can perform, it became actually quite a rigorous model. Of how, with efficient algorithms for carrying it out. Been applied to many, many cases in science and medicine, most recently in the book up in the corner called The Cognitive Science of Science. So let me tell you a bit more about that. So here's an example of, the kind of causal network that a good psychotherapist is constructing. It's not based on any particular case, just on the sort of things that happen a lot. So you want to consider different diagnoses, whether a patient has depression or anxiety, and you can look at different causal factors going into it. Abusive father, work stress, a boss's insult, or spouse conflict causing anxiety. And this would explain different sorts of symptoms, whether the person is sad or not sleeping or weight gain. So you can have lots of different interpretations required to sort this all out. And you might hope to do it with a Bayes network because they're good at this sort of thing, but just realize what the cost is. So you'd have to not only know what the probability of depression is having an abusive father or work stress, but a whole bunch of other probabilities in there about an abusive father and not having work stress, and it quickly blows up into a combinatorial mess. Okay, but from a different point of view, you can look at it for what goes on when someone is trying to do an inference to the best explanation of the situation, and you can do it with constraint satisfaction. So this is an alternative way of thinking about how the mind works, rather than with probabilities or rather with deductive logics. Think of what the brain does, operating as a parallel engine with lots of different constraints and working in parallel to figure out how to maximize those constraints. So what are the constraints in the explanatory coherence situation? Well, they include things like what hypotheses explain the evidence. That's part of it. Also, different kinds of priority that goes into what evidence is based on observation experiments is better. So this isn't a pure coherence problem, and not everything is to be treated equally. On the other hand, as my stories at the beginning suggested, you have to realize that the patients may lie. Part of it is going to be figuring out, is what they're saying true or not, or what are the other reasons why they say it. So psychotherapists often have people very embarrassed or ashamed to tell them things. And so it takes a bunch of reasoning to do that. All of cases where nobody has a clue what the conditional probabilities might be to feed into a Bayesian account, but I think the explanatory coherence will do it perfectly well. You also have to consider negative constraints. What doesn't fit together? Well, that can include different incompatible hypotheses. Now, incompatibility is tricky here because I said you often get comorbidity. That is, people often can have depression and anxiety, but still those can look like alternatives, but you have to figure out cases where they're actually going to be going together. And then from this point of view, the inference that the clinician is making is a matter of maximizing coherence. And in a short talk, I don't have time to go into how to put that all together, but there are good algorithms for doing that, both the neural network ones I mentioned and other ones that we've developed. So this gives you a different picture of what the assessment looks like. It's a matter of, sure, taking in all the information, and that can include the background information that comes from evidence-based medicine. I'm a big fan of evidence-based medicine. If you've got the relevant evidence, you should put it. It's just that it doesn't easily fit into the probabilistic framework. You've got to consider it as some of the evidence that goes into your overall calculation of what's the best explanation of what's going on. Okay, good. I'm going to have time to talk about the pragmatics. When I first started talking about this with Laurette, she told me about cases where the principles of reasoning that you're doing might not seem to fit with a kind of two-step process. The two-step process people were talking about this morning is figure out what's wrong with the person and then figure out how to treat them, but they often get tied in. And it reminded me of some interesting controversies in philosophy that have not been connected with this. One is the question of whether scientists make value judgments. So that is, should a scientist just be able to make an interpretation of the facts, and then after that, values come in when you're making decisions? But people like my colleague Heather Douglas have argued quite convincingly that no, that's not right, that scientists make value judgments all the time. And so you get this interconnections of the theoretical and the practical. There's an area of epistemology that's also addressed this issue with completely different terminology that goes under the heading of pragmatic encroachment. The question is it legitimate to have pragmatics encroach upon the narrowly epistemic considerations? Well, I think that's a very funny choice, because if the scientific question that values are always going to be relevant, then it's not a matter of encroachment. It's not that the pragmatic is getting in the way. It's always going to be a concern of making your judgments based on what your goals are. So that's why I'd rather call it pragmatic enhancement. And I think it's important in any of these clinical situations to see that the pragmatics are going to be there. After all, the aim of the assessment isn't just to get the truth or an explanation, but it's patient benefit. That's the overall goal. So psychotherapists, and I think this is true of physicians in general, need to deal from the start with treatability questions. What's actually going to be doable and feasible and successful? And one goal of that, or one effect of that, is that the information that's gathered about the symptoms, stressors, and triggers is going to be shaped by that. So in a more traditional medical one, it might be what tests you're going to do, but in a psychotherapeutic situation, it's what questions do you ask people in order to get the information you need to deal with treatment. There's also another way in which the treatment serves to test hypotheses about disorders. And so sometimes you're not quite sure which is the right diagnosis, but you can try something, and if it works, that provides evidence that you're going in the right direction. So pragmatic enhancement is operating there, because often some of the only ways to find out whether the hypothesis is right, whether the diagnosis is correct, is to see whether there's a treatment that goes with it. In the therapeutic situation, that can involve trying out various tools from the therapist's toolkit, different kinds of intervention, different kinds of changes in belief or emotions to see what goes on. Okay, well, a big part, I think, of trying to figure out what's going on in the minds of therapists and in physicians is to try to figure out when does it go wrong. There's a large literature on how this works in medicine, almost nothing on psychotherapy, but I think it's going to be the same sort of thing. What are the kinds of error tendencies that people naturally make? This is Daniel Kahneman, famous for starting this line of research with Kahneman and Tversky. So what are some of the big problems? Here I think are some of the main ones. One is motivated inference. People can bias their diagnosis and treatment by personal goals. In medicine, this is often called affective disorder. In psychology, it's called motivated reasoning, but it's the same kind of idea. The idea is if you're too attached to a patient, you may, for example, not do an invasive test because you don't want to hurt them. But of course, if the goal is to help them with their problem, that would get in the order. There's another kind of error tendency that I've only just realized recently is really important. I call it fear-driven inference, where sometimes people just get scared and they bias a diagnosis and treatment by fear of the worst-case scenario. It's close to someone this morning was talking about worrying about minimizing regret. But sometimes just fear is not a particular guide to what's actually going on. Many people have talked about confirmation bias, a tendency of people to stick with the first hypothesis, false cause, just because one thing happens after another, you think it's available there. And there's various other areas that people have talked. Now, the question is, if people were Bayesian, why would they so enormously subject to all these kinds of things? Well, I can actually explain all of these as resulting from coherence effects, and I don't think they'd be explainable at all from a Bayesian point of view. Okay, let's wrap it up. So my general claim is that psychotherapeutic assessment is based on explanatory coherence. The assessment interacts with treatment, and this is not an encroachment, this is an enhancement. That's, after all, what the whole purpose is involved with. And finally, psychotherapists, like all physicians, like all scientists, like all people, are subject to cognitive and emotional biases. And so if you want to give an account of how they're thinking, both normatively and descriptively, there should be a common underlying pinning for what is going on in their minds. And I think that explanatory coherence can handle that. Thank you. I think we got a couple of minutes for questions. Sure, but I think they want you to come up to the mic and identify yourself, please.
Just a quick question. On your view, what impact, if any, will the movement from the diagnostic manual to the RDOC have on psychotherapeutic assessment?
What's the second one?
Research criteria domain. It's based on...
The sort of thing that NIH wants.
Yeah.
Yeah, it's too soon to say because that's not fully worked out. But ideally, you'd get the effect that you already get in medicine. In medicine, once you had a causal mechanism for figuring out what's going on, say a bacterial infection, then you can figure out how to treat that, for example, by killing the bacteria. But unfortunately, the knowledge available in psychiatry isn't good enough to do that yet. So, yeah, it's too soon to say.
So, thank you. Once again, a great presentation. So I just want to ask for a little clarification, because you said that your explanatory coherence approach gets you away from hermeneutics, yet at the same time you mentioned complex interpretations involved in coming to figure out that explanatory coherence. So how does that get you away from hermeneutics if you're offering interpretations of some form?
Oh, sure, that's great. Yeah, you are offering interpretations, but you're showing how to do it both well and badly. So the idea that there's interpretation, that definitely sounds to me on the right mark.
What's a good versus a bad interpretation?
Yeah, okay. So the explanatory coherence theory lays out in a lot of detail what goes into it. So you've got evidence, you've got the data, but you've also got these layers of causality. And it's a matter of figuring out overall what is the best explanation in the way that fits the overall picture. So it spells out what interpretation is as a matter of explanatory coherence. Now, I haven't given you the details of how that works, but there's lots of stuff on that. Yeah, I got several books on it, actually. Yeah. So sure, interpretation's important, but you got to have a rigorous account of what the interpretation is. And I think that's what explanatory coherence allows.
Hi, great talk. Thank you, Olaf Dammann, Boston. I'm working on causal explanation in illness occurrence, and I'm using that model of yours, explanatory coherentism. The question I have is, how do you or how would you model in epidemiology, for example, effects that are not on the outcome of interest, but on the arrow in between the cause and the effect? For example, effect modification.
What's effect multiplication? I don't know.
Modification. That is,
Modification,
in one group of patients, the drug works, but in others, it doesn't. So there must be a third variable that actually divides the two subpopulations.
Do you know what that third variable
I
is?
would know that,
Yeah.
yes. Is in your model of constraint satisfaction, is it possible to model such
I would
effects?
think so. It would probably require simply having more layers of causality. So it wouldn't just simply be cause and effect. It could be cause and cause and cause and cause and effect. And so you could have a bunch of things in there.
Oh, kind
This
of
is
a
the sort of
nested
thing that
causation.
gets very problematic in a Bayesian account because you start dealing with combinatorial complexities. But it works actually pretty well in the explanatory coherence framework. You can have quite complicated layers, and it still ends up being something that you can calculate. So my guess is that's probably there, but I'd have to work through a particular example to show
Let's
that.
talk about it. Promising, thank you.
Good.
Joanne Oravec, University of Wisconsin. I'm wondering what happens when patients self-diagnose, and again, often with the help of the internet. Is that a special sort of layer in your considerations when you, again, it can be considered another aspect of information to include in your analysis, but is it in somehow to be treated as a being of a special order, the self-diagnoses that patients can come up with?
No, I don't think it would be a special order any more than it would be in the medical situation. I know that physicians complain these days that people arrive in their offices with all sorts of printouts, figuring what they've got. But of course, the dangers of that are obvious. They just don't have the same level of knowledge. And the same thing in the psychotherapeutic situation. People might think they've got X, but of course, the job of someone with decades of experience is to figure out whether it's there. What goes into the calculation, though, is simply the data point. The person thinks they've got X. And so that may be one piece of evidence to be explained, but it's not going to have any special priority here because the internet is full of mistakes and people are often very naive about their mental health as well as about their physical health.
Hi, my name is Martin Nash. I was in general practice for 20 years and then I went into psychotherapy. And I'm just wondering, in your experience, how many patients have self-esteem issues?
Oh, I'm not a psychotherapist.
What percentage of patients
I
have self-esteem?
don't know. My guess from the psychotherapists I've talked to, lots. But of course, that's something that needs to be diagnosed. I mean, that needs to be one of the causal features that goes into it. So it's tied in with the sort of things I mentioned, such as treatment by parents. That's often a major issue, is people who've been badly treated by their caregivers are more likely to have it, or partly genetic. So yeah, it's certainly a problem that every psychotherapist deals with.
So every 100% of your patients have self-esteem issues.
Well, I have 0 patients, so that doesn't quite apply. No, because not everybody has self-esteem issues, but many people who suffer from depression and anxiety do.
Okay.
Okay. So I don't have an answer for you.